no a known case of bronchial asthma coming for lap cholecystectomy. This is a clinical scenario case often asked in the theory paper, for which if you start writing an answer like this, first of all, you won't finish it in time. You have because only at the last moment you are mentioning about the word lap cholecystectomy itself is coming only in the last but the third slide. Okay, so it should be a more of a discussion based on the patient scenario that is given to you. So the answer, of course, this is a useful presentation for those who have not had an opportunity to handle a case of bronchial asthma coming for any type of surgery. But to write a theory question in the theory paper, the presentation should be slightly different. Okay, and the first thing all of you should know is bronchial asthma does not come under the category of chronic obstructive pulmonary diseases until the bronchial asthma is of a very long duration, and because of the repeated attacks of asthma, very rarely a prolonged asthmatic patient can become a COPD patient also. But as long as the airflow obstruction is reversible and the cause is an inflammatory mediated bronchospasm, it doesn't come under the category of COPD, even though there is an obstruction to airflow and there is all the features similar to COPD is there. So the major difference for practical exam purpose, you have to know that the major difference between COPD and bronchial asthma is bronchial asthma should be a reversible airflow obstruction. It should resolve with treatment unless it goes into, again, another caveat there is sometimes it may go on for hours together when you call it as a status asthmaticus. Okay, so this is the first and foremost differentiating point that should be mentioned in your theory examination. Now, with regard to the various slides you presented, of course, I think you have borrowed a lot of slides from the presentation made earlier. I also saw those slides in the net. You mentioned about a child who lives in a very healthy or a very safe, unpolluted atmosphere, suddenly getting exposed to a polluted atmosphere and developing a bronchial asthma. Is there any name for that, Dr. Rohan? Are you aware of any name given to a child brought up in a very clean environment, suddenly exposed to an unhealthy or a polluted atmosphere, developing a wheezing? Do they have any name for that condition?
There is a name, sir. I just forgot. I have studied about it.
It's called clean hypothesis. It's called clean hypothesis. Okay, so that is that. But now we are all very much aware about the environmental pollution, global warming. We want to maintain a green and healthy atmosphere. So that is the, even our Prime Minister is now heading the 2G conclave for this particular purpose only. Okay, so this is one of the things that you have to know about when you present that. And one of your other slides where you mentioned about the investigations, you conveniently skipped one investigation called no breath test, which gave an answer of 25, less than 25 ppb for normal and more than 50 ppb for asthmatic. Do you know what that test is? Because you have borrowed that slide from some other presentation. Any idea? Did you try to check up what that no breath test means? Anybody else who knows that? Ammu, Jay Bharati, Teshwar Rao, Sai Dikshit, Jemima. Ramin Kumar, Satyapriyan, anybody can answer. Right. Try to find out that. And how many of you agree with the explanation he gave for closing capacity and FRC relationship? Dr. Ammu, are you there? You can unmute and say yes or no. Dr. Venkateshwar Rao, your mic is off.
Yes, sir.
Do you think his explanation about closing capacity and FRC is correct? He says if closing capacity encroaches up to FRC, it causes the collapse of the alveoli. Is it right or wrong?
FRC is, if it is less than closing capacity, it will collapse. It is,
So
FRC is
closing
less than
capacity should be always less than FRC or more than FRC?
FRC.
Yeah, it should be
Should
always,
be always less than FRC.
Yes, but what happens in pathological conditions or in aging, CC, closing capacity or closing volume, tries to encroach to the value of FRC or sometimes even overtakes the value
More
of
than
FRC.
FRC.
Okay? So will that cause retention or will it cause a collapse?
It will cause collapse.
It will cause collapse.
Yes, sir.
How will it cause collapse? Well, see, before the whole exhalation takes place, the airway starts closing. The alveoli are not able to empty. So will it result in air trapping or will it result in collapse of the alveoli?
Collapse. Collapse.
See, let us say for understanding purpose, the alveoli has got 10 ml of air. Okay. At the normal FRC, 8 ml will be expelled and 2 ml will remain. That is the FRC volume. Supposing the closing capacity or closing volume starts encroaching and the airways collapse even before 8 ml is let out or expelled. At the 60 ml itself, it is the closing. What will happen to the remaining volume? Will it increase or decrease?
Will increase, sir, 4 ml.
See, first you have 8 ml. At FRC, you are able to expel 6 ml. 2 ml is remaining. When CC or CV increases and closing volume occurs early, only 4 ml is going out and 4 ml is remaining in the alveoli. Will it cause a collapse or the alveoli will remain distended?
Distended.
And then why we say collapse? How will it collapse? It ultimately results in air trapping. Okay, so that point is also there. And there is no mention about the use of NSAIDs in bronchial asthma. All the other modalities of analgesia you mentioned, but there is no mention about NSAIDs. Can you give NSAIDs for a bronchial asthma patient, Dr. Rohan? Diclofenac or the other commonly used NSAIDs for post-op or intra-op pain relief. Can you use them in asthmatics? And which is the safest NSAID if at all you want to use?
Selective.
Pardon?
Selective COX inhibitors. COX-2 selective inhibitors.
COX-2 selection. Ibuprofen is supposed to be the safest NSAID that can be used in asthmatics. But with regard to NSAIDs, not all patients with bronchial asthma will develop an exaggeration or precipitation of asthmatic wheeze when they are given NSAIDs, because there is a genetic predisposition to the precipitation of bronchial asthma by NSAIDs. But two, what is the mechanism by which NSAIDs can precipitate a bronchial asthma? Dr. Ramu, how NSAIDs can exacerbate or precipitate an attack of bronchial asthma? Not there. Dr. Venkateshwar Rao?
COX
Prostaglandin, sir.
COX will lead to loss.
Prostaglandin?
So when the COX pathway is inhibited, the other pathway of leukotriene will be
there is only
produced.
one pathway which is affected by NSAID, the blockage of this prostaglandin
Prostaglandin can
synthesis.
like
Whereas the
form.
leukotriene pathway is not affected. Okay?
Yes, sir. Yes,
So
sir.
there is a increased production of bradykinin which can aggravate the bronchial asthma or bronchoconstriction. That is the mechanism by which NSAIDs can worsen the bronchial asthma attack or precipitate an bronchial asthma attack. So as a blanket rule, it is safer to avoid all NSAIDs as a pain relieving drug for patients with bronchial asthma. Okay. So otherwise, it was a very good presentation. So I'll just go on to show how a theory question, if it is asked, you have to present. It is not a elaborate sentence-wise answer. It is more like a tips that you get in the old synopsis of Lee, where you can just go through the points and then remember that, and then in the exam you can, if necessary, elaborate and write it them in a orderly sentence-like fashion. Just,
Yes, sir. Yeah.
the slide visible?
Yes, sir.
So first of all, if such a clinical scenario case is given in your theory paper, first you have to identify what are all the problems or challenges you face in that case. So the first problem here is a patient with bronchial asthma. We do not know, nothing is given about what is the duration of the disease the patient is suffering for, what is the severity, what is the frequency of attack the patient is having, or whether the patient responds to therapy or they have become immune to the treatment. All these things we have to discuss, number one. The second problem is the patient is going to undergo laparoscopy, where you have a raised intra-abdominal pressure because of the CO2 insufflation, which also can increase the carbon dioxide level in the blood, where already a patient with bronchial asthma may be having a certain amount of hypercarbia, and the intra-abdominal pressure has its own effects on the cardiovascular system. So these two are the challenges that you are going to face in the management of a patient with lap cholecystectomy, coming for lap cholecystectomy. So first you can define asthma, that is accepted as a part of the answer. So it's a chronic inflammatory disease of the pulmonary system characterized by airway inflammation and hyper-responsiveness. That airway is very irritable. Even a small stimuli can precipitate a bronchospasm. So it is a hyper-responsiveness resulting in episodic wheezing. Unless it becomes status asthmaticus, where it can be prolonged for hours together, it is usually self-limiting and episodic, comes in small bouts and goes away, which with the cough, breathlessness, and chest tightness, and it's always reversible. Airflow obstruction is there. So once you give the treatment, or sometimes it may spontaneously get aborted and the spasm may get relieved. So it may be reversible and it is episodic. These are the two important characteristics of that, contrary to the COPD patients, chronic obstructive, where there is a permanent small amount of obstruction always present. Whereas in between the attacks in a bronchial asthma patient, the bronchial tone and the bronchial diameters are all normal, like any other patient. Now, when we elicit the history and complaints, you must ask about the years of wheezing or cough, how long the patient, because this is a 40-year-old female that has given in the case scenario, that means it's an adulthood asthma. So patient may be what he described as intrinsic and extrinsic. Extrinsic is childhood asthma and intrinsic is adulthood asthma. So patients who develop asthma after the age of 25 or 30, which is called adulthood asthma, it remains lifelong till the lifetime. Whereas the childhood asthma, which comes at 2 or 3 years of age, by the time they grow into adolescence and adult age, they overcome that. They don't have asthma anymore in their adult life. So this is the important history. First, you must ask what is the years of wheezing and coughing, how frequently they get the attacks, what factors are triggering, like a tube sticks in the house, or oil boiling for cooking, or the house dusting, or spray, scent or powder, talcum powder. All these things can trigger an asthmatic attack. So, what are the factors triggering? And what is the duration of every attack? Does it last only for a few seconds, or it gets aborted with the two puffs of an bronchodilator, or it stays for a longer time? And what are the factors relieving that attack? Then whether there is any history of hospitalization previously with the attack becoming very severe, not getting relief by outpatient treatment. Was there any necessity for the patient to get hospitalized at any moment of time? And what is the effort tolerance of the patient? How are they able to do their normal day-to-day work? So all these and very associated cardiac, obesity problem, dermatological, neurological, or other respiratory system infections, all these things can be associated. So all these questions have to be asked. 1, 2, 3, 4, 5, 6, 7, 8 questions have to be asked with regard to the history of this. And the patient description of breathlessness is based on the cause. Always you can differentiate, because breathlessness can occur due to an asthma. It can occur, as he said, because of cardiac condition. It can occur because of even simple exercise can make you breathless. And patients can develop breathlessness uh, if they have uh, in asthma, it is tightness in chest or air hunger. So always they say something constricting my chest. I'm not able to take a deep breath. Then in uh, congestive cardiac failure, patient says it is suffocating, as though there is no ventilation in the room at all. And in COPD, the patient says, I have to make a lot of effort to take a breath. So you can easily differentiate. So if the patient says, I get breathless on and off, you should not just stop there. You must ask them to explain what type of breathlessness they have. And from that description itself, you can identify the etiology or the cause of this. So in asthma, it is tightness of chest with air hunger. In congestive cardiac failure, they feel suffocating, as though there is no air in the room at all. In COPD, they say it takes a lot of effort on me to take a breath. But in exercise, what will the patient say? They will feel they are exhausted. They will feel very tired. That is what the description the person suffering from breathlessness due to exercise will say. Then you must take a detailed history about the treatment that is taken, and that can give you a clue about the severity of the disease. So patients may be taking oral medications also, like the aminophylline tablet or salbutamol syrup, or they can be on inhaled medications and steroid therapy. These are the three important modalities of medications that the patient or treatment they take. And when they say they have been taking steroids, the next question is whether they require it continuously every day, or they take it only intermittently, say twice or thrice a week, or occasional, maybe once in 3 months, once in 4 months. Some people may be having a budesonide or some other steroid inhaler with them. If you ask them, they will say, it is 3 months since I used. I had a mild attack 3 months ago. After that, I have not used. Other people will say, I will use it 2 or 3 times a week. Other people will say, I have to use it every day, morning, afternoon, and evening. Otherwise, I will get an attack. So, continuous, intermittent, and occasional use. And when was the last use? And if the patient has been on a continuous or a long-term use of the steroid, whether the patient has got any effects of even inhaled steroids can produce systemic effects in the long-term usage. So the patient may have Cushingoid appearance, and which drug gives them the best relief? That is an important history that you should elicit from this patient. So some patients may get a very good relief with salbutamol. Some patients may get a very good relief with tablet deriphyllin or injection deriphyllin. Even today, some patients will say, unless I take an deriphyllin injection, I am not clear. Doctors have tried inhalers, nebulizer, everything, but I am best relieved only with IV deriphyllin. And some patients in the olden days, they used to come to OP, the government hospital, to take an injection of epinephrine subcutaneously. So the drug which gives them the best relief also should be noted so that you can use them. And coming to the physical examination of the patient, we must make a general physical examination with regard to the facial appearance. Because if the patient makes a pursed lip to take in inspiration or expiration or during expiration, that means it's a very severe asthma. And posture, these patients may have a leaning posture. They may be looking anemic because the repeated asthmatic attacks suppresses the ability to eat and make them anemic because of the nutritional deficiency. Or when it turns out to have repeated infection, they may have clubbing, and they may, in spite of this asthma, some people may be, especially in the lower socioeconomic status, they still may be smoking. So all these features should be looked for. And when you come to the systemic examination, you must look at the RS for any uh, accessory muscle activity, which shows the severity of obstruction and whether the patient is obviously dyspneic even at rest. And sometimes when you go near the patient with severe asthma, you can even hear the audible bronchi. They can have that cooing sound audible when you are examining them. And when you do the palpation, you must do the chest expansion measurement, and you must check for the vocal parameters and vocal resonance. And percussion, you must look for any hyperresonant note. Emphysema test changes which have happened in a long-standing bronchial asthma, as I told you, which can get converted to COPD. There may be a very resonant note, or if they have associated tuberculosis with an effusion, there may be dullness. And you must auscultate for the presence of wheeze and exact locations, which part of the lung is more actively wheezing, whether there is any rals which may indicate cardiac involvement like carpulmonale, or silent chest. When there is no air entry at all, it is a very ominous sign that patient may be having such severe wheezing, there is no air entry at all. So a silent chest patient is a very dangerous patient. And look for serious changes like carpulmonale right heart failure, that is distended JVP, fetal edema, abdominal hepatomegaly, all these things have to be looked for. Then coming to investigation, you must do CBC and other system routines like urea creatinine, uh, the bleeding time, clotting time, all the routine tests that we do for any surgery, that also should be done. And you can do a sputum examination to find out the difference between an allergic asthma or an infective asthma. With microscopic examination, you may find the eosinophils and macrophages, or you may find the bacteria and macrophages with the CD4 or CD8 also may be identified. And a chest X-ray usually shows a increased bronchovascular markings or tubular heart, and echo will be useful to find out any early increase in pulmonary pressures or right ventricular strain. And PFT you do mainly vital capacity, FEV1 measurement, and wind expiratory flow between 25 and 75. This is a very important thing to identify the presence of bronchospasm because it is patient independent value. And minute ventilation. And lastly, an ABG is a must for all bronchial asthma patients to rule out whether they are in any normal status or whether they have type 1 failure or type 2 failure, you must respiratory failure, you must do an ABG for all bronchial asthma patients. Then coming to pre-op optimization for elective surgery, you must continue the regular bronchodilator therapy as per their need. As I said, that is where the continuous, intermittent, and occasional patient usage of bronchodilator comes into play here. And you can give them the incentive spirometry to use them for improving their uh, uh, pulmonary functions. Then patient should be free from an asthmatic attack because these attacks come sometimes in seasonal variations. Some patients get it in the severe winter. Some patients get it during the harvesting time when the pollens are more in the atmospheric air. Some patients get it in summer when they sweat a lot. So patient, you should also find out that also the triggering factor. And for any elective procedure, it is better to do in the season where the patient has got the least number of attacks. Then coming to the intraoperative management, wherever feasible, you can do the regional technique because you can avoid the airway handling or stimulation by in the visual tube or other airway placements. So wherever possible, a regional technique is always advisable. So there are a lot of papers which have been presented using epidural or even intrathecal central neuraxial block for lap cholecystectomy or other abdominal procedures also, but they have their own limitations because why we don't normally prefer a central neuraxial blockade for lap cholecystectomy? Any idea? Can you do this or not? A high risk respiratory patient. Can you do it under the epidural? The only drawback is it will produce shoulder pain because the diaphragm is irritated with the pneumoperitoneum that you create. So the patient may have a shoulder pain. That is the only problem. And otherwise, you can definitely do it. There are segmental epidural or continuous epidural blocks which have been tried and successfully used for even lap surgeries in but in theory paper, you have to write it with a caution. Don't write it blanket wise that you can definitely use it. And when it comes to the question of using GA, these are all the drugs which are safe, considered safe: propofol, etomidate, ketamine, and as he mentioned, even thiopentone is good enough, but it does not suppress the airway reflexes as much as propofol does. And you can use midazolam also. And with the relaxants for usage, of course, you have to avoid succinylcholine because that also can cause histamine release and bronchospasm. But in case of anticipated difficult airway, you have to take the risk and you can use them. And but the safe relaxants will be vecuronium, cisatracurium, and pancuronium. And among the volatile, alethane, which was available earlier, now going obsolete slowly, was the best bronchodilator volatile anesthetic agent, both in adults and children. And isoflurane and sevoflurane, that is the order of bronchodilating capacity. And among the opioids, pethidine is supposed to be very good. It has a structural similarity to atropine. So it causes a good bronchodilation and also reduction in secretions. So in the olden days, we used to prefer pethidine for intraoperative use. Nowadays, you have fentanyl and alfentanil available. When you want to reverse the effect of on the progressing muscle relaxant, sugammadex is safe for if you use vecuronium. But if you use neostigmine, you have to give it in a very titrated, slow fashion because neostigmine itself can precipitate a bronchospasm. So you can give a dose of bronchodilator and then slowly give a titrated dose, if possible, using a neuromuscular stimulator and assessing the recovery. Now, examination, they may ask you, and also in the theory, it is better to write management of intraoperative bronchospasm. It's a very common question in the Viva exam also. So you have to uh, classify it into machine causes and patient causes. So intraoperative tight bag or bronchospasm may be due to machine causes or patient causes. Sometimes you keep a very high fresh gas flow, like 3 liters of oxygen and 6 liters of nitrous oxide. That was the flow used in the olden days by many anesthesiologists. But now many of you are aware of the low flow techniques. So, sorry, not many use that. Or sometimes the oxygen flush may be partially struck and the oxygen may be flowing without a big noise. So you may not notice that. Or there may be a kink in the tube or circuit. Or when you use the circle system, there may be a valve which may be stuck, especially the expiratory valve, if it is stuck, that also can mimic a bronchospasm, or a partial block in the endotracheal tube, that also can mimic a bronchospasm. These are all machine causes, and patient causes commonly endobronchial tube and a sputum in the airway, or a precipitation of a real bronchospasm, or it may be a pneumothorax. Sometimes very high pressures used during bronchospasm in order to overcome the hypoxemia. You give high squeezing pressures, then you can produce a pneumothorax, or it may be a pulmonary edema because of the cardiac conditions, or there may be a barotrauma. Okay, so drugs for relieving the bronchospasm, usually we try to identify how do you differentiate between the machine cause and the patient cause. What is the simple test you can do? Rohan, supposing after
Auscultate.
intubation you find the bag is tight and you are not able to ventilate the patient, how will you find out whether it is the machine cause or the patient cause?
Auscultate with bag ventilation.
Auscultation, you find the wheezing, bronchite, that's all. How will you know whether it is caused by the points I have told you, caused by the machine, or whether it's a problem with the patient? Who else is there who can answer that? Some see better if unless you answer and come back with a feedback, it is not interesting to take the class. You can attempt. Venkateswar Rao.
Sir, you can take a vein circuit and check it.
Vein circuit. Why a vein circuit?
Sir, to rule out any machine causes.
Vein circuit or an ambu bag is better.
The ambu bag.
If you use a vein circuit, you are going to again fix it only to the anesthesia machine. You are not eliminating the machine. So whenever you get a doubt whether it is because of machine or because of the patient, you simply disconnect the circuit from the patient, keep the endotracheal tube, attach an ambu bag and start squeezing with your hand. If you are able to easily ventilate, that means there is nothing wrong with the patient. It is a fault in the machine. Then you check for all the points or change the machine. There may be a stuck valve at the circle system, which you would not have checked during your preliminary examination. So you have to just change the machine. On the contrary, with the ambu bag also, you are not able to ventilate the patient. Then you have to think of patient causes. Okay, so this is a very common question asked in the practical Viva exam also. So you have to know this point, right? And what are all the drugs that can use intraoperatively if there is a bronchospasm? Clear cut, all the other causes ruled out. There is a bronchospasm. Then this mnemonic I always try to tell you, it's the same chick. So S stands for salbutamol, A for aminophylline, M for magnesium sulfate, E for epinephrine, C for chlorpheniramine maleate, H for hydrocortisone, I for ipratropium bromide, and K for ketamine. These 8 drugs can be very handy when you get a bronchospasm. So one or other may be very useful to relieve the bronchospasm. Coming to the next part of the problem, that is laparoscopy management. You must have an ETCO2 continuously working. whether you with all the other monitor, a ETCU monitor is a must for all laparoscopic procedures. And when the surgeon is insufflating to produce the pneumoperitoneum, the CO2 should be insufflated slowly, and the lowest intra-abdominal pressure should be maintained, not more than 10 to 12 centimeters of water. And patient should have been adequately hydrated to produce a good hemodynamic stability. And if you are using a ventilator for ventilating the patient, use lower tidal volume. Sometimes you can use higher respiratory rate if the patient's CO2 is high already with the ABG, or you can use a low respiratory rate also. But the IE ratio should always be 1:3 or 4 or 5. The expiratory pass should be more than the inspiratory time. And you should use the minimal peak because these patients are likely to develop an auto peak. So you must use minimal peak so that you can avoid barotrauma. And watch the airway pressure carefully so that you can detect an early increase in the airway pressure either due to bronchospasm or due to pneumothorax or pulmonary edema. All these things can be easily identified by watching the airway pressure, which should not exceed 20 centimeters of water. And all the measures to correct bronchospasm or removal of the mucus plug barotrauma should be there. And in severe cases, patients who have been identified as severe bronchial asthmatics in the pre-anesthetic assessment, it is better to have a arterial line and do repeated ABGs to identify the effectiveness of your intraoperative ventilation. And these patients are likely to develop perioperative pulmonary complications. So you must know what are all the causes for perioperative pulmonary complications, which again can be classified into patient-related causes and surgery-related causes. So the patient-related causes are if the patient is more than 70 years or ASA grade more than 2, and if they have an albumin which is less than 3. Why albumin? What is the importance of albumin in the assessing the risk for periop complications? What does albumin less than 3 indicate? Poor nutritional status. Okay, and if the patient is a smoker, or if the BMI is more than 30, obesity, or comorbid conditions like diabetes, hypertension, and if the patient already has a decreased effort tolerance, these patients you have to watch out for periopulmonary complications. Similarly, surgery related, usually general anesthesia produces more chances of periopulmonary complications. And if it is an upper abdominal surgery, definitely post-op respiratory excursions will be very much restricted. So they also can develop. And if the surgery duration is more than 3 hours, that also can contribute to periopulmonary complications. So these are all the points that you have to mention in your answer for a question which says a 40-year-old female or male coming for with bronchial asthma coming for lap cholecystectomy. This is the way you have to present your answer.